Thank you very much, everyone, for joining tonight. It's a great privilege to be able to talk on this webinar. So I was given the task of talking about the latest science in cardiac arrest. My name's Keith Couper. I'll summarise my conflicts of interest, which will also give you an insight into who I am. So I work across the University of Warwick, University Hospitals, Birmingham NHS Foundation Trust. Most of my life is spent doing research in the world of cardiac arrest and intensive care. Alongside that, I've got a number of volunteer roles. So I work with the International Liaison Committee on Resuscitation, member of the ALS Task Force, European Resuscitation Council, and Resuscitation Council UK. I have a number of different roles within those organisations. I've had I work on a number of different research projects around cardiac arrest, some of which I may talk about tonight, or if people want to ask questions about them at the end, they're obviously more than welcome to. And I'm also an associate editor of Resuscitation Plus journal. So that's kind of where I'm coming from when I present to you tonight. What I was planning to do was to give you a very brief overview of UK out-of-hospital cardiac arrest epidemiology. For those based in the UK, none of it will be a surprise to you. So 5 mils of 10% calcium chloride with the first adrenaline and 5 mils of 10% calcium chloride with the second adrenaline. I think when it's, certainly my practice is when I would give calcium chloride is I would give 10 mils of 10%, 6.8 millimoles immediately, rather than do that staged dosing. So it may or may not represent exactly what happens in clinical practice, but the message here is really important. And what they essentially found was, and I'm going to talk us through this slightly slowly, is this is the plot showing the results, and I've put in the red box at the top the overall results. So what you can see is that when we talk about return of spontaneous circulation, which was their main outcome, if you had calcium, 19% of patients got return of spontaneous circulation. If you had placebo, 27% of patients got return of spontaneous circulation. So quite a big difference numerically there between the proportion of patients get return of spontaneous circulation. And when you look at the difference in risk between those, you can see pretty clearly it's favouring saline, albeit ever so slightly crossing that line of no effect there. But when we look at this whole plot of looking at every single different group that we might possibly imagine, we can see pretty clearly that across all of these different groups, in no group does there appear to be any beneficial effect of calcium. So it seems that there's certainly no benefit. And I think, given that overall result, we need to be really thinking about, is it actually causing harm in patients when we give calcium in cardiac arrest? For me, one of the key reflections of this, and I think we've often got this concept of, if you're in cardiac arrest, you can't do anything to make someone worse because it's the worst position they can possibly be in. I think this really does challenge the assumption of there's nothing worse than being in cardiac arrest. To me, this is just highlighting that key message of we can make people worse, and we really need to be really careful about the treatments that we're giving and thinking about why we're giving them and what. Looking at the list of people at the beginning of people on the chat, many of you work for ambulance services that are participating in the PARAMEDIC-3 trial. So thank you so much for your efforts in helping to make the PARAMEDIC-3 trial a success. And for those that aren't aware, PARAMEDIC-3 is a very large randomized controlled trial comparing an intraosseous first strategy versus intravenous first strategy for drug administration in cardiac arrest. And along with some other trials that are going on throughout the world, that will really be our route to understanding how best to treat and what drug routes to use. I'm going to talk very briefly about E-CPR. There's a lot of excitement about E-CPR. Again, I think it's, I think we've got two pictures here that really demonstrate the challenging nature of E-CPR. And both setting up the system, but also having the right personnel and resources to be able to deliver it is incredibly complicated. Again, we've got this Goldilocks concept of when do you start 𝐸-CPR in cardiac arrest? If you do it too early, what we end up doing is putting big tubes into people and having the risks associated with 𝐸-CPR in people that might well have got a return of spontaneous circulation and good outcome from conventional CPR. But then if we wait too long, what we've got is this situation where it's possible that the hypoxic ischemic brain injury that's happened during cardiac arrest means, again, even if we can restart the heart, unfortunately, what we end up with is people with poor neurological outcome and perhaps not living the life that they want to lead. So again, I'm going to remind you of this slide that I showed at the beginning of, you know, when in this, if we focus on our VFVT type arrests, and I'll show you the clinical trials in a second that have looked at this area, but you know, at what point in this process should we be starting 𝐸-CPR? How low does our survival have to be before we start to think about the potential benefits of 𝐸-CPR might outweigh its risks? I think that's a very challenging question that we don't yet have the answer to. So there's been a number of trials of 𝐸-CPR. I've listed the 4 randomized controlled trials here. The first one, the arrest trial that was Demetrios Yiannopoulos in the US, really had extremely impressive results, and that really focused people's minds and interest in 𝐸-CPR. Unfortunately, what we've had subsequently is the fact that the subsequent trials really haven't this is where we are at the moment, trying to avoid hypoxemia and trying to avoid hyperoxemia in patients with return of spontaneous circulation in any setting. So not being too liberal, but perhaps the exact trial probably gives us some food for thought about, well, we want to avoid hyperoxemia, but it's almost certain that hypoxemia is worse, but we don't, it's incredibly difficult to titrate effectively in that setting. So the last thing I just wanted to cover was around survivorship. I think this is becoming a really important topic, and increasing recognition of the pre-hospital response to out-of-hospital cardiac arrest is incredibly important. If people don't get high-quality CPR, if they don't get early defibrillation, if they don't get advanced resuscitation, all of what might happen in the hospital setting is redundant because the patient is not going to be alive to receive that treatment. So that early part of that chain of survival is the most important part. But what we're increasingly recognizing is the fact that we've very much focused on that early part of the chain of survival and focused on the in-hospital bit of it with our intensive care, but perhaps missed the recovery phase of it. And certainly the AHA, the Europeans are still catching up, really, is recognizing that recovery really is a part of this chain of survival, and we want to get people to recover in the way that they want to recover, and we need to give them the support to enable them to do that, whether that's physical rehabilitation, whether that's psychological rehabilitation, whatever they need, but then we need to know how best to deliver that care. This is I think, summarising what I've just said and how all those stages of that chain of survival really feed into that central part of this, which is the survivor, their family and the community in which they live. And I think, you know, when we have all that joined up, that's when we really do get the best outcomes from cardiac arrest. So with that, I'd like to thank everyone for their attention, and I'll hand back to our moderator.